Hello and welcome to the antiemetics lecture. Today we're going to talk about nausea in general and the drugs we use to treat it. So there could be a lot of different sources of nausea and a lot of different symptoms that go along with nausea, but we'll be focusing on just primarily the nausea, vomiting, reflexes that happen in the body and how we correct that and prevent that from happening. There's a lot of different options available, and there's a couple different mechanisms of action that have all been shown to have some sort of antiemetic potential. First of all is the muscarinic receptors. So drugs that are anticholinergic, so antimuscarinic on the M1 specific receptor, seems to have some sort of an effect. Dopamine, histamine, serotonin, abbreviated 5-HT3 there, and neurokinin 1 or substance P, which is a specific chemotherapy thing. All these receptors are thought to be present in the chemotrigger zone in the central nervous system, which causes the reflexes that make us feel nauseous and make us vomit. There's not really a lot of studies out there actually comparing antiemetic agents head to head, so a lot of what we talk about is just anecdotal evidence, or we use things based on studies that are used. So for example, it doesn't necessarily mean that if something is only used for chemotherapy-induced nausea and vomiting, it doesn't necessarily mean that it's not useful in other types of nausea, but that's just the way it was studied, so that's generally what we use. And again, administration route can be important too. So if your patient is vomiting, oral routes are going to be really challenging, so you're going to have to look at something that is either going to fast dissolve in their mouth or injection. So let's start with anticholinergics. Scopolamine is one I want to talk about really quick. This isn't really a anti-nausea drug. It's more of a prophylactic agent, and we use it for motion sickness. That's probably its most common application. People will put it on before they go on a cruise or something, and you can replace, it's actually a transdermal patch that goes on behind the ear, and you replace that every 72 hours. But it doesn't work very quickly, so you want to put it on 2 to 4 hours prior to need. Now, I will say that we do use scopolamine patches in inpatient care sometimes as well. So, for example, anesthesia might put it on sort of towards the end of a surgical procedure so that it helps with a long-term antiemetic effect as they go into post-op recovery and things like that. So sometimes they do that. It's not super common, so I'm not sure if there are certain procedures, or it depends maybe on what type of anesthetic agents they used or how long they were under, but they do use it occasionally. The big thing to remember about it is that it does take some hours to work. So if somebody is coming on with a patch and they've only had it for an hour and it's like, oh, it's not working, you take it off, well, you didn't really give it enough time to actually do anything. The side effects, because this is anticholinergic, it's going to cause dry mouth, so it's probably going to be the biggest one people experience. Otherwise, because it's not an oral anticholinergic agent, you don't have as much GI-related side effects. People aren't going to get constipation with it, generally. They might feel a little drowsy, and you might see some vision disturbances as well, but generally, again, much better tolerated than your average oral anticholinergic agent. That's really it for anticholinergics directly. However, antihistamines tend to have anticholinergic properties too. So diphenhydramine or Benadryl can be used as a antiemetic agent. It comes IV, IM, and PO. It's very similar to scopolamine as far as why we use it for motion sickness, but it's very sedating, and it's much more anticholinergic systemically than scopolamine. So its effects are going to be more pronounced than the scopolamine patch. Antihistamines, Benadryl specifically, are OTC. They're easy to obtain and generally okay to use in pregnancy. So if you do have a pregnant patient with nausea, this is an option they could try. Promethazine is another antihistamine that is actually kind of blurring the line into some of the other drugs we're going to talk about that have some dopaminergic activity as well. And promethazine with codeine sort of got famous as a cough syrup, as an antiemetic cough syrup type thing, and mostly got famous because of its abuse. I can't remember who this was. I think it was Soulja Boy or something. Anyway, he posted like a picture of a bunch of promethazine codeine bottles on his Instagram or something like that, and that's something really stupid. Like, why would you do that? Obviously, you didn't get a prescription for 6 bottles of promethazine codeine, but I don't think actually many companies make this anymore because it was basically just being abused. I don't think anyone was really using this therapeutically because it doesn't really have any benefit over other therapies. So I don't know if it's really available anymore, but I'm sure some other company decided to make it. Okay, so that's really it for antihistamines. Basically, promethazine, codeine aside, you can use, again, just to reiterate, you can use diphenhydramine as an antiemetic. So that's going to be something that comes into play occasionally. And I should say that promethazine without codeine is called Phenergan. That's the brand name of that drug. So you might hear that come up occasionally. I feel like that's gotten maybe some more use in obstetrics recently. So in the kind of especially in the later stages of pregnancy, I might see it used in the hospital here and there, but it's not a super common item. It's again a bit weaker than the other drugs we're going to talk about here, so you might see it used occasionally. It does come injectable, so you could give it to somebody via that route if you wanted to. And that's again just the plain promethazine or brand name Phenergan. Dopamine receptor antagonists are kind of the mainstay of nausea and vomiting agents. It's the ones that are going to be used fairly regularly. And they're really the oldest group that we have that were originally designed, or at least showed significant clinical benefit in treating nausea and vomiting, specifically with chemotherapeutics. Also, these drugs kind of cross over into the antipsychotic realm. So a lot of these have similar structure or similar activity to the way that some of our early generation antipsychotics work, albeit they're a little bit different and they're much less potent versions. So you don't really get. We haven't talked about antipsychotics yet, of course, but we're gonna get to that, and just keep that in the back of your head that these don't have quite the same potency and side effect profile of those drugs. In fact, they're much better tolerated, fortunately. So prochlorperazine or compazine is one of the more common ones we use for nausea and vomiting. It's actually doesn't have a ton of clinical evidence surrounding it, but most people think it works okay, so we still use it. It's again a really old drug that we've been using for years. Becomes IV, IM, PO. Also has a rectal suppository available. And again, it's one of our go-tos in this category. It's probably the most popular one in the dopamine receptor antagonist category. Chlorpromazine is an alternative, and not really as popular for nausea, but I wanted to put it in here because it's sort of an odd drug that is actually used for irretractable hiccups. So if you work urgent care or ER, every once in a while you get somebody in who is in because they have hiccups that just won't go away, and this is kind of the first option that they'll give people to treat that. Side effects. These acronyms we haven't talked about yet. EPS stands for extrapyramidal symptoms, and TD stands for tardive dyskinesia. These are two really common effects, not common, sorry, they're sort of hallmark side effects related to antipsychotic use. Extrapyramidal symptoms are sort of like Parkinson-like symptoms, tremors, movement disorders, things like that. They come on fast and they go away when you take the agent away. So that's something that you can actually treat with diphenhydramine. So something anticholinergic can actually prevent that from happening. So if you have somebody who maybe has a history of that and you really want to use prochlorperazine, just pre-medicate them. Usually with prochlorperazine, though, it's not a substantial amount of people are going to experience this, so we don't pre-medicate. We just usually assume it's going to be quite rare with that. Remember, it's just going to be a lot less common than with your full-on antipsychotics. Tardive dyskinesia is a more severe, permanent side effect that causes most commonly facial tics. So similar kind of movement disorder type, in that family of side effects, but really rare, ultra rare with prochlorperazine. A couple other options. So two drugs here, droperidol and haloperidol. These again are antipsychotics or antipsychotic derivatives. Droperidol is this drug that's been on and off the market for years. It's actually kind of back right now, which is weird because when I was a resident in pharmacy, this was back in 2011, 2012. This was the go-to drug for nausea in the ED. We used it all the time. It actually works pretty well for acute agitation too at higher doses. So it was a really popular choice. And then it disappeared from the market. I think people just started using alternatives. And now that it's back, people don't use it quite as much. But it is something that people are getting back in the swing of trying. But I don't think anyone wants to rely on it because you don't know if it's going to disappear again or if the manufacturer's just going to up and decide they aren't going to make it anymore, which is basically what happened at the first time. Haloperidol is, you can see that their names are very similar. Droperidol I think of as a shorter acting version of haloperidol. So about 2 hours versus an 18-hour half-life. Haloperidol is a first-generation antipsychotic, and while I said that droperidol and prochlorperazine are similar to those drugs and they have effects like those, they're much less likely to cause issues. Haloperidol is a very, very potent first-generation antipsychotic, first and foremost, and an antiemetic second. So this one is one that you would really be concerned about side effects. So I wouldn't ever give somebody haloperidol unless without pre-medicating them. So I'd absolutely give them diphenhydramine, or sometimes we give another drug that called benztropine that we haven't really talked about yet. But anyway, something anticholinergic to pre-medicate them to prevent symptoms from happening. Because if somebody's going to get EPS or TD, haloperidol is going to be probably the culprit. Here I say it's rarely used for nausea and vomiting because in my experience, and up until recently, I had never really seen this used for nausea and vomiting. Maybe a couple times. And I asked one of my friends who works in the ED now more than I do, and he's like, yeah, I maybe used it once or twice. You don't use it very much, and basically it's if you run out of all types of other options. The problem with Haldol or haloperidol is that it's so long-acting, it's profoundly sedating, and the side effect risk is significantly higher. So most people probably aren't going to go down that road for acute nausea and vomiting. Now, I will say that at Abbott, our anesthesia group switched over in the past couple of years, and they like using haloperidol in the post-op setting. So in our PACU, or post-anesthesia care unit, they will use this as their second line option after the next, I think, well, in a couple of slides, we're going to talk about a drug called ondansetron, which is a very popular antiemetic as well. But anyway, this is the second line option, which is very different from what we've been using in the past. And I don't know how comfortable I honestly am with it. I think if it were me, I get that they probably want a sustained effect from it. And if you're going to admit somebody to a patient care unit, you don't really care if they're sedated. So it probably depends on if somebody's going to go home after surgery or maybe go into the hospital. But I don't know if personally I would want this, just because it does have a much higher incidence of side effects and it doesn't have the greatest safety record. In fact, it's fallen out of favor as an antipsychotic because of that, because we have safer medications that work better. So I'm not really sure I totally understand the use of this, because I know that talking to a lot of my other clinical pharmacists, we all kind of scratch our heads as to why they went this direction with it. But that's what we're seeing now. So post-op use is more popular, and again, this anesthesia group within Alina wasn't practicing at my hospital at Abbott, and we never used haloperidol in the PACU. And when they came over from their other location, they were really shocked that we didn't, because they asked me for a report on how often we use it. I'm like, we don't use it. We don't use it ever for nausea and vomiting. So they have kind of changed that practice. So anyway, you might see different things done with that. Again, I'm a little leery, but mostly it's because I don't have a ton of experience using it for that. And I'm coming from a mental health background as well. I'm more familiar with it in those patients, which makes me a little nervous to use it in anyone as a second line option. But again, that's just my little soapbox there. So don't necessarily say that Chad said that this is wrong to use. I think there's much more precautions you need to take when you're giving somebody haloperidol than when you give somebody prochlorperazine or droperidol. And then the next one is Reglan, or metoclopramide. Metoclopramide has a similar mechanism. It's got some dopamine receptor antagonism, but it also works with serotonin and has some anticholinergic effects as well. Sorry, that should say anticholinergic, not cholinergic. It's available IM, IV, and PO. Side effects are similar to the other ones we've talked about. And one thing to make sure is, even though this drug is kind of different, you don't want to combine it with another dopamine receptor antagonist. So the other two drugs we've talked about, or the other classes of drugs, or the other two slides, I should say, prochlorperazine, chlorpromazine, droperidol, haloperidol, you wouldn't combine those with metoclopramide. You kind of pick one in this group. So out of those 5 drugs, you're just going to pick one. You're not going to go with any others. And if that doesn't work, you have to basically wait until that drug's out of their system before you might want to try a different one. Whereas you could give diphenhydramine in combination with any of these. So you can mix and match your classes, just don't double up on your dopamine antagonists. And the reason is, the more of those you give somebody, the higher risk of these movement type disorders people will experience. Antiemetic effects don't appear to be as potent as other D2 antagonists. There's some studies out there that show metoclopramide isn't quite the level of potency as like prochlorperazine, but again, the evidence is pretty mixed and limited and small, so we don't really have a firm grasp on that. I think if you ask people, they would probably say metoclopramide's maybe a little bit lower on the potency spectrum, but it's still a useful drug. Okay, so that's really it. There's some other options in the dopamine realm. Some of the newer antipsychotics that we haven't talked about, called second generation antipsychotics, are getting more play in nausea treatment, especially one called olanzapine or Zyprexa, which we'll talk about during psych more. But that's one you might see as well, specifically for acute nausea and vomiting. We use it more in the ED, and which is why I'm kind of surprised that one hasn't caught on for post-anesthesia care and why they're using haloperidol and not olanzapine. Olanzapine is much safer, and it has very potent anti-nausea effects. Actually, quite a good drug for that. It has a lot of side effects with it, but usually when you give it short term, it doesn't really do much other than cause sedation. So it's a popular choice for that option. And you can give it IM or IV. Anyway, that's just my kind of soapbox there. So again, the haloperidol thing has just been a big practice change for us that we haven't seen in the past. So I'd like to see more evidence on that and why they're using that really to really convince me. But that's just kind of what my real life experience has been. So again, depending on where you go, you'll see all types of protocols and order sets developed around these different drugs, and usually an antiemetic order set. Like if you're admitting somebody to the hospital after they've had surgery, you're probably going to have some antiemetics on there. And it's usually going to be some sort of specific protocol where they have a first line, second line, and maybe a third line option to try. And it will be something within this group of drugs will be on there. All right. Right, serotonin receptor antagonists. The 5-HT3 specific receptor target within the chemoreceptor trigger zone and works on the vagal nerve to decrease outflow of receptor transmission to prevent nausea and vomiting from happening. Serotonin receptor antagonists are probably the most common first-line useful drugs. They're the cornerstone of any type of nausea and vomiting treatment. And again, they're almost always first-line. And really, when I say them, I'm talking really about one drug. There's a bunch in the category, but there's one that's really commonly used. The rest are sort of mostly only reserved for specific chemotherapy-related indications. So pretty much every different delivery form is available. Interestingly enough, these have all been tried against each other, and most clinical trials have shown there's no real difference over them, with maybe the exception of one called palosetron. All right, so the big one is ondansetron. That's one for sure you should know like the back of your hand. You're going to use it in basically any type of practice you would go into. It's going to be the thing that you want at the top of your head for any time somebody has nausea. Probably going to be the first choice you're going to pick. The reason is it's really safe and it's fairly effective. So this could be used from anything from chemotherapy-induced nausea and vomiting. It's our first line for post-op nausea and vomiting. And again, that's what they'll give people in the PACU until they maybe need to go to, at this point, haloperidol based on our current practice. It comes as generic, as injectable. It comes as an orally dissolving tablet, which I will caution you, even though it's generic, it tends to be kind of expensive. So if you're so what we see sometimes is people getting rejected claims from their insurance company because they won't pay for the ODT and they want them to take the oral tablet. The orally dissolving tablet doesn't absorb in the mouth, so it doesn't really give you a huge benefit of onset because it still has to go through the GI tract and absorb. However, if somebody's having a really hard time swallowing like a pill, perhaps maybe the dissolving in their mouth and being able to swallow it with some water might be a little bit easier for them if they're really nauseous. The other ones I'm not super concerned, they're really chemotherapy specific use. I don't see them much outside of there, so that's all I'm going to say about them, just to know that there are other drugs in this class. Again, these drugs are very well tolerated. Mild headaches, the most common side effect with 5-HT3 drugs, and it's about 15 to 20% of patients. The other thing that comes up occasionally with these is QTC prolongation. That's really only a risk if you're giving relatively large doses of these medications and giving it scheduled. So if you're giving like 8 milligrams of ondansetron every 8 hours, that could maybe put you at risk. And especially if you have some other drug on board that might prolong QTC. By themselves, we don't generally get super worried about that side effect. That kind of goes for QTC prolongation in general. That's always the way we look at it. How much drug are they getting, and what other drugs are they getting that can prolong QTC? Usually you need a couple QTC prolongers on board to make a difference in that side effect being something we clinically care about. But you might see some QTC prolongation with these medications, I should say. Glucocorticoids, they're very effective, specifically for chemotherapy. However, we can use them for any type of nausea. Dexamethasone sort of is a cornerstone of a majority of chemotherapy anti-nausea regimens, but it's useful for a lot of other situations too. I think about this one as something that you could potentially use in a pregnant patient who has really bad nausea. It's not an ideal source, but it's going to be safer and better tolerated when compared to some of the dopamine drugs that we just talked about that might not be the best for pregnancy. So it is an option there. Cannabinoids, I thought I'd bring these up just because they do have some antiemetic capability. However, from a pharmaceutical product perspective, we don't really have the greatest selection. Now, there's, of course, medical cannabis out there, and some of that has, I think in Minnesota, there's some indications related to nausea, specifically chemotherapy-induced nausea, I believe, and also for appetite suppression around some of these diseases. But there are a couple different options out there. There's dronabinol, which is Marinol. Marinol is basically THC, and it's been used for a number of different indications. Probably the most common one it's used for is for appetite stimulation. It's a really rarely given drug. We don't see it dispensed a whole bunch. Nabilone or Sesamet, I've never seen used. It's a CB1 receptor, so a cannabidiol receptor antagonist, which is going to be different than just giving somebody like pure CBD or pure THC. And the side effects are going to be vertigo, hypotension, possible dysphoria, and they're both quite expensive medications. So people will respond differently to these, and I honestly think at this stage, what people are probably more likely to do is seek out medical cannabis versus trying a prescription product. And that's probably the direction we're going. It's a little unfortunate, in my opinion, because I would like to see more robust studies. And I think if we had better pharmaceutical grade agents in that space, we would maybe be able to get some better randomized control data. Whereas since it's kind of going into the no man's land, not FDA regulated space of medical cannabis, we don't necessarily have that data. Although I think Minnesota is doing an okay job with that. We're trying to do some data analysis and clinical studies around our medical marijuana program, but still you have lots of places in the country where people are just taking it based on a recommendation or based on a theory. We don't really have a lot of evidence. Most of the evidence around using cannabis is based on studies around dronabinol. We don't have a lot of studies that directly support different strains or different blends of THC, CBD percentage and things like that. So I don't know if we'll ever get there at the point of, I think the market took off faster than the science will ever be able to catch up to it. But maybe at some point we'll have a better, more well-rounded, evidence-based approach to using cannabis for medicinal purposes. But right now we're not really quite there. But I just want to point out there are a couple prescription products that do have nausea, anti-nausea capability. And then benzodiazepines. So these are another drug class we haven't talked about, but mentioned a couple of times so far this year. These aren't traditional antiemetics and are probably not going to provide a lot of relief, but they are really helpful if somebody has acute anxiety on top of their nausea. So sometimes this is actually pretty common, at least what I see in the ED. People come in nauseous and they're actually pretty anxious about their whole what's going on. I'm nauseated. I don't really know what's happening. And so benzodiazepines can help with that acute anxiety component, which can also help with the nausea component. And benzodiazepines are also really commonly used in chemotherapy, nausea and vomiting regimens too. So they are well proven for this. It's just they aren't really our first line. They're habit forming. the likelihood of abuse is quite high with them. And so if we can avoid them, we do, but they are helpful in certain situations. Lorazepam is probably going to be the one that's going to be used the most, or Ativan. And we'll talk about these drugs in more detail and what exactly they do, but they're sedating, and just for the purposes of this lecture, they do have antiemetic effects. So summary, your first line really depends on the situation. I can't think of a situation where ondansetron isn't first line. So again, that's the big one to remember as far as, what's my go-to. You can't really go wrong with ondansetron or Zofran. Even I don't think I mentioned pregnancy, but even pregnancy, it's widely recommended in that category as well. Though there's some debate around that, and I'll talk about that during the obstetrics stuff we talk about in the summer. But basically, yeah, anything that's going to be involving nausea, you're going to want to think ondansetron as a first option. It's really popular for that and really common. Your second option is probably going to be a D2 antagonist, something in that space. So prochlorperazine is what I would generally go to. Droperidol is a nice choice too. Metoclopramide is a nice choice. I'm still going to ride my my high horse here and say that haloperidol should be reserved for situations where you really can't get anything else to work. And just remember that you should never give haloperidol to somebody who can't be sedated for 12 hours afterwards. So I think one time I had a colleague get a couple of like emergency medicine physicians get upset with each other because one of them gave somebody Haldol for nausea, and it was, then they had to basically sit in the ER because they were passed out and couldn't go home for a while, and that kind of took up a bed. So anyway, there's issues with that specific drug. So shorter acting stuff in acute medicine, fine. If you're going to use something really long acting like haloperidol, just consider where they're going to go and if that's appropriate or not. Remember, one big thing, don't stack up your D2 antagonists. All the dopamine antagonists can be used, but not together. And then your underlying cause, of course, you'd want to address that if you can. So that's basically it. I've got a quick little case here. This is a patient, BK. She is a 23-year-old female. She presents to your emergency department with acute nausea and vomiting, secondary to a migraine headache. You order ondansetron and prochlorperazine. She reports some relief, but your nurse reports that she just had an episode of emesis. What other options are available? So if you want to pause and think about this, go ahead. So there are a couple things you could do. The first thing I would approaching this case, if somebody came and asked me about it in the ER, is I would see how much ondansetron they had gotten so far. There's a max dose. Usually it's about 8 milligrams, but if they got, and usually you give 4 at a time. So if they got 4, I'd give probably another 4 and make sure you max out that ondansetron first. Prochlorperazine you've used, so you're going to have to wait and not give any type of dopamine antagonist until that drug has been worn off, basically. The other thing you could try are a couple different classes. Antihistamines, so diphenhydramine might be an option for this patient. I would certainly look at lorazepam as a benzodiazepine, especially if the patient has some anxiety. They have a migraine headache, so how have you approached the pain management? Have they gotten ketorolac? Have they gotten a triptan drug, which we're going to talk about those coming up when we talk about neurology in the next module, but making sure that you're addressing that side of it too, because if you can stop the migraine, you probably will be able to stop the nausea as well. Consequently, the nice thing about these drugs is they're actually useful for migraine too, so prochlorperazine in and of itself can have anti-migraine effects as well, so there's that option, or that added benefit, so you might have that to consider, but we'll approach that later. So you have a lot of options you could try. You could even try steroids if you wanted to, but really getting the migraine under control and then making sure you aren't doubling up your dopamine antagonist is what I would think of as your main goals for approaching this particular patient.